Welcome and thank you for joining us for the very first episode of Digital Health Transformation, a new webinar series from Data for Life. In clinical research today, we struggle with the basics. Patient care, respecting longitudinal data is rarely practiced, even less so taking into account public health data. We are still far from leveraging multimodal data, integration of imaging, lab results, genetic and wearable data. Meanwhile, clinicians work in systems that prioritize billing codes over accurate representation of the patient's disease. And while the art of medicine is a vibrant concept from past times, evidence-based medicine requires addressing algorithmic and human bias. We talk a lot about innovation, but for many researchers and physicians, the daily reality is fragmentation, friction, and frustration. Adoption is one key obstacle, and trust and buy-in from the patients is a corresponding challenge. So how do we design digital systems that not only solve technical challenges, but earn trust from the people who use them, the patients, the physicians, and the researchers? And what happens when we stop treating data as a commodity and start treating it as a public good? That's why we invited two experts for today's conversation who know both worlds, the clinical practice and system-level digital health infrastructure, Dr. Girish Nadkarni and Dr. Alexander Charney. And I heard you had some trouble coming all the way here to Berlin, but you made it.
We made it.
Okay, great. And to introduce you would probably take a day longer, but just briefly, Girish holds several leading positions at the Icahn School of Medicine at Mount Sinai and Mount Sinai Health System in New York. He's the chair of the Windreich Department of Artificial Intelligence and Human Health at the Icahn School, director of the Hasso-Plattner Institute for Digital Health, and inaugural chief AI officer of the Mount Sinai Health System. With a background spanning mathematics, clinical medicine, public health, and informatics, he has authored hundreds of publications, co-founded AI-driven health tech companies, and is driving efforts to embed artificial intelligence, governance by design, and data-driven infrastructure into large academic health systems. And joining us is Dr. Alexander Charney, professor at the Icahn School of Medicine at Mount Sinai, with appointments in psychiatry, genetics, and genomic sciences, and neuroscience. He is also the director of the Charles Bronfman Institute for Personalized Medicine, which hosts the Mount Sinai Million Health Discoveries Program. As a physician scientist, he works at the intersection of brain biology and data science, focused on translating genomic insights into experimental therapeutics that can truly make a difference for patients. Dr. Girish Nadkarni and Dr. Alexander Charney are not only clinicians and researchers, they are co-leaders of the RMS initiative, a transatlantic collaboration between Mount Sinai, HPI, and Data for Life. They represent a new generation of leadership in global health, one that sees data as a public good and builds infrastructure that earns the trust it depends on. We are honored to have you both here, and we are excited to hear your perspective. So in today's conversation, we focus on the defining tension of our time. Can we trust the AI systems that are reshaping healthcare? And more importantly, how do we design trust into these systems from the beginning? We will share insights from your work building multi-center, transcontinental, interoperable digital health systems, exploring how trust, governance, and ethics must be built into transforming from the very beginning. To explore this, we'll try to look at trust as a basic for patients, researchers, clinicians, and society at large, because only by connecting these viewpoints can we begin to build systems that people truly trust in. So let's get started. So we have seen in the past tremendous improvements in oncology, and I mean what used to be like a death sentence in the past has now been addressed with targeted therapies and checkpoint inhibitors. But access to data made that in particular feasible, such as the Human Genome Project, the Cancer Genome Atlas, and making clinical trials findable and retrievable through clinicaltrials.gov. But this is not the norm, that's the exception. There are many therapeutic areas that haven't benefited from that transformation. So can you maybe speak to that, and what are the challenges and what do you see is required to change that?
So that's a great question, and thank you again, Ben, for having me and Alex on the call. So I think one of the key questions here, at least in the US, is right. Healthcare is kind of fragmented between multiple payers, multiple health systems, multiple sort of different organizations, and regulated by several both state level as well as federal. This. Now, while decentralization and federation creates a competition to be the best, that also creates some amount of fragmentation in the data system. So patients' health records are not sort of complete because they can go to one health system for primary care, go to another health system for specialty care. When they are acutely sick, they get taken to the health system which is closest to the house. So the third thing, so health records are all over the place, and that's in my mind a missed opportunity because at one health system you just have a sort of a fragment of the data. Now, there are initiatives in place trying to sort of reconstruct the whole trajectory, including both patient-led initiatives coming from the consumer level digital ecosystem, for example, Apple Health, where you can download all of your data from different providers with Smart on Fire endpoints, for example, right? But I think that there needs to be a bigger sort of push in place in order to integrate all of these data types in one place and to give rise to a more longitudinal, holistic view of patient data. And I think that that will help sort of chronic diseases in a couple of different ways, right? One is when you have longitudinal transition points at scale, you can identify sort of inflection points or transition points in patients' health, right? Especially by integrating longitudinal multimodal data. And if you can identify those accurately, there can be modifiable factors that you can target. For example, body mass index in diabetes or cholesterol levels in cardiovascular disease, and you can do that at scale, especially if you know where you're targeting. And the second point is that if you have this longitudinal history or sort of longitudinal trajectories on patients, you can actually sort of get more insight about what group of patients respond to what group of medication and so on and so forth. And this has been shown in the large sort of health consortia, including Odyssey, that has done this across the world and use this for as if not to replace, at least to inform better design and better targeting of treatment trials. So, I completely agree with you that data should be sort of harmonized and made longitudinally available so that we can both think about the research of the future, but also the clinical care of the future.
Wonderful, thank you. And maybe, Alex, you can comment on that. You already mentioned a couple of words into our audience. Some of them might need some explanation, but given that the US spends so much money on healthcare and is one of, or maybe the highest, has the highest degree of digitization, why is it so challenging to build these longitudinal multimodal data sets? And then how does that play into patient care?
Yeah, so our health system in the U.S. Does have a lot of digitization, but it's completely fragmented. So we don't have a single electronic medical record that spans like our entire country. The closest thing we have to that in the U.S. is our Veterans Health program, the VA system we call it, which is a single health electronic medical record. It's been around for decades and contains records from millions of veterans across the whole country. It's totally integrated. No one has access to it for reasons you can imagine. Even if you're within the VA system, which both Girish and I have been at various points in our career, and you're a leading informaticist, accessing that data is still really hard, let alone like training models and running computation on that massive data set. So you do have like some practical challenges in the U.S. despite us having moved to digitizing our medical records a long time ago. It's not as if we have this beautiful longitudinal data set of our entire country's health. For individual health systems like Mount Sinai, we've gone the process for going from paper records to electronic records it wasn't like a single like just one shot deal. Kind of took place over the course of years is actually still taking place in our health system. We just had one of our hospitals go live on Epic, and to be integrated in. That's the medical record system we use at Mount Sinai. So, our first hospital went live on Epic like 20 years ago, and we just had another hospital go live. So it's like this process is not smooth. It takes a long time, and then for a given patient, the reality you have is some of their records are in the electronic medical record, and some of them aren't. Their doctor's notes may live in one place, their imaging data may live in another place, and their EKG data lives in another place, and if they've got an EEG, that lives in another place, and this information isn't integrated. And even at the most advanced academic medical centers, which we consider ourselves one of those, this is still a major challenge, right? So how does all of this builds into the question of how does this relate to how do we take care of people? And the reality is our data is so fragmented that the challenge of putting it all together to then develop tools to take care of people better, utilizing data as a public good, like you're saying, is something that we have to tackle.
These are great points, and maybe to either of you, you talk about the challenges and the limitations due to data access, the fragmentation, and then in addition we have GDPR and HIPAA. But then on the other hand, we also have the commercialization of data and also consumer health. So we have two different worlds, and if you look at patient care and the challenges that you pointed out, we don't see that much in the commercialization and the industrial space and the consumer health. So how do you see that? I mean, should healthcare move maybe to a different section of industry, or what is your opinion here?
So I think you raise a very interesting point, right? On the one hand, you have this push towards data as a public good, but then on the other hand, you have this push towards data as a commodity like oil, right?
Yes.
And those two things seem to be in conflict, but at the same time, if done thoughtfully, insightfully, and with rigor and governance, those might not be in conflict, right? Well, first of all, I do think that patients should be consented at scale for any use and reuse of that data, which we do in the Mount Sinai Health System. But at the same time, I do think that the motivations of the commercialization of the data need to be thought about pretty carefully, right? Because it's not a one-size-fits-all. I mean, where you develop a product that's ultimately going to lead to better lives of patients is a very different thing than using that data for tracking or other means, right? So I do think that there needs to be a mindset shift towards data as a public good, not a brokerage form of it, not data as oil, but data as soil, because oil is just extracted and consumed, and soil is, cultivated, reused, regrown, etc., right? So I do think that there needs to be a mindset shift, because not all commercialization, this is my opinion, is bad, because that ultimately leads to scalable benefits to patients that single health systems or single companies may or may not provide, right? But at the same time, patients need to see those benefits come back to them, and they need to consent or at least and be informed of what their database is being used for, including development of new products. And what we found in most of our research as well as most of our clinical care is that if patients not only see the benefit to themselves but altruistic benefit to society as a general, they are much more they are more than willing to donate the data as a public good and a public utility, right? So I do think that the intention behind commercialization, the framing behind commercialization, patient participation and patient participation and sort of almost willingness to contribute data are all key things, right? But this is a nuanced discussion, in my opinion.
But these are great points, and it really displays the shift from the doctor-centered approach to the patient-centered approach, which also requires different metrics and the buy-in of the patient, and having them involved in patient care and in terms of information flow. But maybe that's a great opportunity to talk about the RMS project and the collaboration between these three institutes. Maybe you can speak to that, what makes it so unique and why this is really novel and innovative.
Yeah, absolutely. The ARMS initiative, the acronym stands for AI Ready Mount Sinai, and it's a partnership between Mount Sinai, House of Platter Institute, and Data for Life. And at the foundation of the ARMS initiative is the creation of a unified database that captures the many sources of health information flowing through the Mount Sinai health system, of which there are several hundred, and they're not integrated. Health systems in the U.S., and I'm sure it's true, the world over, weren't designed to be these engines for discovery, like electronic discovery. I mean, they were designed before computers existed. What's come to be over decades is this really fragmented system of data that is not where the information about one thing is not connected to information about another thing in a way that could really be leveraged by AI scientists to make discoveries that then can change healthcare. So that's the problem ARMS is solving. First and foremost is creating this database that allows researchers to gain insights into healthcare delivery, health outcomes, and the like through analysis of massive data.
Okay, great. Thank you for the description. And then you almost demand a leap of faith of the patients, because first you give access to data, but then you layer AI on top of it, and there might be some misunderstanding, and people all use ChatGPT and LLMs and confuse a little bit the concepts. But maybe you can bring a little bit light into the dark.
So I think it is a leap of faith for the patients, but like I said earlier, there's intentionality, there is beneficence, and there is transparency behind this, right? The patients at Mount Sinai are usually consented for both secondary use of their data, both broadly, but also through the Mount Sinai Million Health Discoveries program that Alex leads. Patients who do not want this are automatically removed from any and all data sets through a ETL pipeline. And then we do de-identification in most cases. And then there's pretty strict IRB regulations, which is for protection of patients, the Program for Protection of Human Subjects, PPHS, that evaluates us every 6 months to make sure that we are meeting the standard requirements or exceeding the standard requirements as required by HIPAA, but also by GDPR, because this is a transcontinental partnership, right? With all that being said, I think that there is also an outreach to patients through sort of media channels, et cetera, to show how ARMS is actually creating discoveries that will benefit health of not just patients like them, but them at the future, right? So ultimately, the patient is at the center of it, because they are doing us and science and the world a great service by letting us utilize their data in a safe, secure, and privacy protected manner, but still letting us utilize the data for the purpose of scientific discovery. So I do think that, like, patient, and I say this and you are a clinician as well, and so are you. We say this. Any of the work that we do, be research, clinical care, or operations, the patient is at the center. So truly, in this case, the patient is at the center.
Wonderful. And maybe, Alex, especially for your patient cohort with like psychiatric diseases and some other challenges, how do you see the opportunity of using AI in addition to the doctor, and maybe think about the human in the loop?
Yeah, absolutely. And to add on to what Girish was just saying, patients have trusted their doctors forever. Like the notion that you go to your doctor and you share the most personal information imaginable is just kind of foundational to going to the doctor. And I think what we're talking about is really like the modern version of that. Like that data is being stored to train models, just like the data before the existence of AI was being used to train physicians. If physicians seeing patient after patient is getting smarter, applying the lessons learned from patient 1 to the treatment of patient 2. It's just all being done with the human brain instead of a computer. And the modern day version of that is using each patient's information to make the whole system smarter. So I think there's some level of just built-in trust that you go to your doctor, you're sharing the most personal information, all of it. You're sharing your social security number, you're sharing your credit card number, you're sharing all your health information, you're sharing health information about your ancestors, your children. So like you're already doing that, and there's this, you are vulnerable, but you have that trust in the health system, and it's on, this is why it's so important that this work be done within health systems, and that Google and Apple aren't the ones doing this, and because they don't have that same level of trust with patients, and they haven't earned it like a place like Mount Sinai has over the course of treating people for hundreds of years. So that's what I'd say to that part. With respect to the mental health in particular, there's immense opportunity for artificial intelligence to transform the field of mental health. The language is where AI is, really showing immense success. The ability for computers to understand language, engage in conversation, and that's the kind of foundation of psychiatry as well. So you see a lot of these AI therapists being marketed already based on no data, no evidence of efficacy. So it's totally unregulated. It's the Wild West, but the potential is real. So there's this immense potential, but also immense need for rigorous, old-fashioned, randomized clinical trials to see, do these AI tools really help? I think the potential for them to hurt is at this point pretty well kind of documented in the public sector, newspaper and whatnot, with anecdotal reports of people who have either hurt themselves or had other negative interactions with AI that where the outcome of that kind of is attributed to the AI itself, like an AI encouraging someone to kill themselves. Those risks also need to be studied, so we don't blow things out of proportion, right? Can an AI chatbot really drive someone to suicide? That's a question that rigorous scientific research needs to be done right away to answer that. So we don't, overblow the risks, but also if that risk is real, we attack it right away.
These are wonderful points, and I mean, you mentioned that it requires trust as the foundation, and then you have the opportunities, but then you mentioned also the requirements and the framework that you have to set. And some of these points are not just technical in terms of security, but also some of the important questions are ethical questions. So maybe you can talk about that, how RMS in the setup is especially tailor-made for these challenges.
So ARMS is specifically tailor-made for these challenges because of several things, right? One is because of this unique collaboration that we have with Data for Life and HPI. We have to adhere to not just HIPAA but GDPR, so that requires highest standards of security, privacy, privacy protecting infrastructure, right? The second thing is with the tooling that we build on top, we have to do that in a very rigorous and intentional and evidence-based way, right? And get which we do get user feedback on each of one of those tools, right? The third thing is the AI models that we build on top eventually will be taken, which we are already doing. For example, we built an AI model for blood glucose monitoring after cardiac surgery on ARMS that's being taken through its trials right now. But we needed to take it through silent deployment, which basically means evaluating it prospectively and seeing how it works. But depending upon the risk of the model, maybe and quasi-experimental study, either a randomized controlled trial or an A/B test, depending upon the risk of the model. And then depending on whether how close it is and how physicians or providers use it to make clinical decisions, FDA regulatory pathway and EMA pathway is probably ideal, right? So I think that it starts off with data, but then you have the layer of model building on top of it, and then you have the layer of governance / monitoring on top of it, and then eventually the layer of deployment.
Wonderful. And maybe to go one step further, with all these tools and technology available, does it require for the patient to acquire AI literacy to be a corresponding patient that is compatible with the system? What's some some of the requirements or thresholds, or what is the change in patient care from that perspective?
Yeah, that's a really interesting thought experiment. It can't require the patient, right? So healthcare delivery needs to meet the patient where they are. So to me, the question is as new tools are developed that utilize AI, they won't be adopted if they require, right, the patient to like do something they don't normally do. So think of an extreme example. A patient who doesn't have a cell phone, right? If you move your health system completely digital so that unless you have an app, you can't interact with the health system. You can't schedule appointments. You can't, like go see the doc, right? So it's like without that phone and that app, you essentially, as a patient, can't be part of that health system. Well, that's not going to work, right? The patient is not going to, change their life in order to fit into the healthcare system. Generally speaking, that's what you see as a clinician. You just get the sense of that. Patients, you have to meet them where they are. They won't take a medication, if it doesn't fit into their daily life. Or if it is inconsistent with how they want to live their life. A medication that, in my field, I specialize in the treatment of psychosis, and our medications make people gain a lot of weight. Well, patients with psychosis are like everyone else. They want to look good. So they don't want to take medication to make them gain 100 pounds, right? So they're not going to take it. So, as the innovator who develops a new treatment, if you don't take that into account, you're developing treatment that no one's going to want. And I think that's the same with AI. So people have to want to use it, and it needs to meet them where they are.
Fantastic. And before we go to the third and last part of this webinar, maybe you can just give an example of what you've learned in terms of best practice or major challenge for the audience and the listeners that you've learned from the RMS implementation.
So I think the best practices that we've learned from the ARMS implementations are best practices and building to two different guidelines or guardrails, right? Both the HIPAA guideline as well as the GDPR guideline. The other best practices that we have learned is how to integrate sort of multimodal data at scale, and integrating it after you've extracted it is not hard. It's like finding it and building the extraction and transformation and loading pipeline that is hard, right? And the third thing that we've learned, and this is most important, is when you are building for deployment, the data structures have to be very similar to what you're eventually going to deploy in, right? Because if you build an OMOP, for example, which is a common data model, and you're deploy in Caboodle, which is a different data model, then there's after building, it becomes a lot harder to, transform it into Caboodle, as opposed to if you think about this intentionally from the start. So those are the three major things that I have personally learned.
Great, fantastic. And that leads us actually to the third part. And you spoke about global scale, and maybe that's self-advertisement, but how does data to evidence really level the playing field? Because what we see frequently is that technology is actually a divider, because it creates more inequality, because it's confined to countries with the resources and the money, and that leaves low to middle income countries frequently further behind. So maybe you can speak to that point.
Yeah, I think data to evidence levels the playing field both within an individual organization, but then also globally. Because I can see just within Mount Sinai, Mount Sinai lives this particular part of New York City where we bridge one of the wealthiest area codes and one of the poorest area codes. Right? We treat both of those groups of people. So you can see within how data to evidence helps level the playing field, because we have people in our health system who are these super experienced engineers and machine learning experts, and they can interact with the machines and the data to do really exciting things, make discoveries, et cetera, et cetera. Okay, how's that helping particular group of patients? Well, data to evidence can help open up that pool of information to other people in our health system, people who have no training in computer science, providers. So providers who are working in clinics that are like super under-resourced, and the ability to have like a data scientist in there, like helping analyze the patient data and outcomes, forget it. I mean, those clinics are overrun. They're busy. Their waiting rooms are filled. So having the tooling to make gaining insights from data available to the everyday provider, that changes the game. Now, so many more minds can be thinking through what the data can teach us and how we can learn from it. And then just with that, externally, I think that same principle applies. Now you start looking at, countries or cities or what have you that typically don't have those capabilities. Being AI literate, as a health system or AI functional, whatever you want to call it, can really be that the definition of that can be changed through data to evidence.
Wonderful. And having that said, maybe we can look a little bit more into the future in terms of your plans, what you want to do with RMS, and then also maybe address some of the misconceptions and we alluded to that before briefly, when people think about AI just as ChatGPT or LLM. Maybe you can talk.
Yeah, absolutely. I mean, just to take a step back, right? AI, as in defined broadly by algorithms learning from data and continually getting better, has been around for a long time, right? And predictive models in which update on new data have been around, and we've deployed them for the last 10 years. Large language models, which gives you a way to interact with a knowledge base in a conversational fashion, that is what has sort of brought AI to the public lexicon, right? So sort of predictive AI and generative AI are two very different things, because one is, if you run a same data set to a predictive algorithm, it'll give you the same answer every single time. It's very deterministic. But if you run the same question on a different day through ChatGPT, it might give you a completely different answer. So it's very non-deterministic, right? It's probabilistic. And those risks have to be baked into healthcare, right? Like, for example, predictive models need governance and assurance on different things, right? Making sure that the performance doesn't change over time because of dataset changes or dataset drifts, but also making sure that there is no bias by subgroup, like it doesn't differ performance by subgroup. For sort of generative models, because every time the answer might change, you have to think about governance and assurance quite differently, right? And for that, it's important to have sort of trackability of those answers, auditability of those answers, as well as some interpretability about why the model is performing those answers, right? And that's where I think that we should think about how to not just develop both predictive and generative models, but think about how to test them. Like Alex was saying earlier, if you want to change clinical practice, big assertions require big evidence, right? So we have to hold these approaches to the same standard, I think, that we as physicians hold a lot of medicine, right? We wouldn't give a drug that wasn't proven in clinical trials or other approaches to our patients, right? So if this is impacting clinical care, we have to hold it at least to some of the same standards as we do other interventions in medicine, right? But we also, because this systems change over time, we also have to make sure that we monitor and assure them over time to make sure that there is no change in performance, there's no bias, there's no harmful outputs, et cetera, and sort of build guardrails around them. And I think that's where AIRMS could go, right? In addition to building the solutions, it could become the one place or tech stack for a learning health system where you build solutions, but you also assure them, pre-deployment, then you deploy them, and then you track them and monitor them over time, right? And I think that is what is missing, because there's the healthcare AI paradox, right? We do a lot of research in academic medicine, very little of it gets translated into clinical care, but on the clinical sort of IT informatics side, there's a lot of deployments. If you ask them how many they've actually researched, the answer is very few. So, we sort of we don't implement and deploy what we research, and we don't research. And so we basically have no idea, how, if the approaches that impact patients' lives are safe, effective, responsible, and ethical, right? And we want to change that.
That's great. And so when you talk about translation from clinical research into clinical practice, the next step would also be then the translation and validation from RMS to other countries and populations, and also address the diversity of patients.
Yeah, I think RMS, what we've learned in the last 2 years of leading the RMS effort and building it out from an idea into an actual system is the portability of it. It needs to be a consideration from the beginning. If you design a system that's only built to work in one health system, then it's not going to have its maximal impact, right? And sometimes in the case of RMS, I would argue this is an example where it's not just a simple piece of software you download, right? So that like any place can do it, because it's a system. It involves humans, it involves computers, it involves databases, it involves AI algorithms. So there's a lots of moving pieces. Setting it up isn't as simple as click a button and download it, but it can still be portable, so that you could package this as this is how you set it up, and make it functional within a complicated healthcare delivery system like we work in New York City. If it can work there, it can work anywhere. So I think that's something we've learned a lot about over the last couple of years, and it does tie back to meeting people where they are, because some aspects of this system may work at Mount Sinai, but going to another country and setting it up, it's just not going to work there. So it's going to have to be customized to their situation, but that's okay. As long as like the overall concept, I think, doesn't change, right? Like every place in the world is going to be connected, is going to have data, is going to need to make sense of data to take care of people better, and ARMS is the platform to do that.
Wonderful. And I would love to explore these topics even further with you, but we are coming to the end of this webcast. And maybe as the last question, just briefly, if you had a magic wand, what would you like it to do? And how should the future of healthcare look like?
If I had a magic wand, the future of healthcare should look personalized. So we don't do one-size-fits-none treatment. It should be proactive, so that we basically anticipate things before they're being to happen. And if we have a high degree of certainty, we prevent them. And also it should be patient-centered, right? Which we believe it is, but in a lot of situations right now, just because of the financial pressures, the patients might not be at the center. So sort of proactive, personalized, and patient-centered.
Yeah, for me, more specific, I went into medicine and my field of psychiatry and AI and genomics to cure schizophrenia. So that's my mission as a professional, and if I had a magic wand, that's what I would use it for.
Amazing. So I'll try to summarize some of those thoughts, but what really resonated with me was that data is not an asset, it's not the new oil, it's actually the new soil. And what you build with that, and how you enable the future of digital health and digital healthcare, with prevention at the center, not to wait until a patient is sick, but to be able to act before that, and have the patient in the center. And that would actually mean not the patient in the center, but the human in the center. And so to enable that, we need systems such as RMS that have the aspiration of being global and to grow at scale, and incorporate AI in a really ethical and responsible fashion, so that you can really trust what AI does as a tool to enable equality and fair healthcare and use of data, and having the patient as an active contributor with the understanding and the access as the owner of their own data. And I think that's where this collaboration really comes in and shines, because if you look at things from one angle, you can be an expert, but it looks completely different from a different angle. And so the synergy here from HPI, from Mount Sinai, and Data for Life as a tech enabler, but also a scientific consultant, is, I think, the opportunity that we have, and I haven't seen that anywhere else. And I think that is really remarkable. And so maybe some reflections that really stand out from today's dialogue is that first of all, you have to set the framework. You need the governments, you need the security, the regulation, but then you also need that collaboration. You cannot confine it on one single location. You have to validate it at other locations, and with that create the benefit outside of your first endeavor. And then third, maybe to connect the different worlds, not just the different silos and the different departments and the different actors in the healthcare system, but also connect research and clinical care and create this learning healthcare system. So this conversation is only the beginning. And until our next episode, I invite you all, our listeners, our colleagues and partners, to reflect on these questions that are so valid. And we need a new generation of doctors and scientists that are aware of that, understand that, and can be a facilitator and consultant at the same time as they are clinicians and researchers. And so we would like to continue this conversation on LinkedIn and our networks and through future collaborations. And finally, let us remember, systems can scale, but trust must grow. Let's ensure we are cultivating it deliberately, transparently, and together. Let's keep building trust together, one step at a time. Thank you for being part of this dialogue.